Hello, welcome to the orientation to home visiting services account reporting. In this video, we will talk about the introductions to home visiting services account, data flow to Department of Health in Washington, the home visiting unit at Department of Health. We will talk about enrollment and service utilization, also demographics, and a little bit about allied performance measures and performance payment measures. Now let's dive in. So why is data important to the home visiting services account? It's important because it helps us to understand the impact of home visiting services on children and families. It's help understand what works, what doesn't work, what can we improve. Also, is to tell home visiting success stories to stakeholders and also to ensure the accountability to our funders. This is a snapshot of how the home visiting services account data pathway work. Home visitor serve family collecting the data and help us input the data into Visit Tracker or other programs. And from Visit Tracker or from the data system is sent to Department of Health. We received a monthly or quarterly data extract, and from then Department of Health processes and analyze the data. Then we share the result with home visiting services TRIO account, and also we share the data back to the LAAs. The LAAs use the report for CQI and quality assurance. Also, the result that we share with Home Visiting Services account TRIO, including DCYF, Department of Child and Youth Families, and Start Early, send it to Department of Child and Youth Families, report to funder and policymakers. From then, policymakers and funder makes decision on maintenance and expanding programs, and will make the funding go back to the home visitors served families. Data support available from Department of Health for local implementing agencies include training and technical assistance on required data elements, handbooks for data collection and reporting website. Data products include quarterly dashboards, semi-annual quality assurance reports, and annual performance reporting. This is a snapshot of home visiting unit at Department of Health. There's 4 key data categories for home visiting services accounts are enrollment and services utilization, demographic information, allied performance measures, and performance payment measures. These categories also organize the same way in our data collection webpage. Let's talk about required enrollment data elements. These data elements are collected at enrollment, whenever a funding code changes, and at exits. Different demo, intern, guardian, and child information will be shown in different videos. For funding code, every family served must have an XI funding code. Without home visiting services account funding code, we will not receive data on that family. 4 codes are used: McV, 502, GFS, and 10F. Parent guardian consent must be consent within the first few visits with a family. It is imperative that consent is discussed and obtained. This consent is different from the PAT consent. Please refer to specific consent module to learn more about this subject. Consent for home visiting services. With enrollment into home visiting, the parent or guardian must consent to participate and share routine program data. For example, visit dates, screening results, child date of birth, and basic demographics. Consent to share personal information. This is a different consent. We ask all parent guardians to provide a second consent one that allows for sharing of confidential data, or PII. PII is personally identifiable information such as name, address, guardian date of birth, Medicaid number. The services won't stop if parents don't consent to share PII. Consent form available on Department of Child and Youth Family website. For enrollment date, families, caregivers, and children will not be included in measures without an enrollment date, because without enrollment date at DOH, Department of Health, we cannot calculate all the measures. Exit date, families will continue to be included in measures even if inactive until an exit date is reported. Exit status include completed program, stop services before completion, and exit reason including withdrawn, transfer, loss to follow-up, began return to work, began return to school. This section will talk about service utilization data elements. These data elements include visit and encounter type. For visits, we want date of visit are reported and type of visits including in-person, or virtual, or phone, and the duration of visit. Visit definition must meet the model definition. Encounter data elements, we want the date of encounter are reported, type of encounter, for example, phone, port drop-off, texting, group encounter, and the duration of encounter. These data elements help us determine enrolled families, active and inactive families, or exits. The second key of home visiting services account data categories is demographic information. Data collection for guardian demographics are a requirement for home visiting services account. We want to collect demographic data at enrollment and update at least annually thereafter. The consent is only collected once at enrollment, but will update it only if the status changes annually. This is a snapshot of what to collect for guardian demographics and child demographic. The data demographic needs to be collected at enrollment and updated at least annually thereafter. Let's talk about guardian demographics data elements first. The first four that need to be collected are gender, date of birth, ethnicity, and race. And these are response options available for the answer. The next data elements needed for guardian demographics include marital status, primary language. For other programs, there is some more include a long list of languages that you can choose from, but these are the basic home visiting services account and McVie categories. The next data element is educational attainment. The next data elements for guardian demographics are employment status and housing status, and these responses are available. Next data elements are needed for guardian demographics are household income, including average monthly income, number of people dependent on the income. The next one data element is health insurance status, including Medicaid, private, child care, or no insurance coverage. This section will include data collection for child demographics. For home visiting services account requirement, we also want to collect child demographics at enrollment and update at least annually thereafter, just like guardian demographics. For child demographic data elements, we also want to include date of birth, gender, ethnicity, and race. And these are response options available. Another HVSA data elements required for child demographics are health insurance status and usual source of medical care, which is where the child is taken for usual medical care treatment. This section we will talk about an overview of Align performance measures. Program that's receiving home visiting services account funding required to report on a set of Align measures, including breastfeeding, not applicable if family is not served during pregnancy, depression screening, well child visits, child maltreatment, parent-child interaction, early language and literacy, child developmental screening, and IPV screening. Though data and how to collect data will be soon you can find on our Department of Health data collection webpage from DCYF website. Why collecting data for home visiting services account performance measures are important? It's important because it's a requirement from the home visiting services account to address these home visiting benchmarks. There are 6 domains typically addressed in national home visiting programs, but we focus on 4 of these with our home visiting services account funds. Each domain has a set of indicators that we track. The first one is improved maternal and newborn health. We use depression screening, breastfeeding, and well child visits to address and improve the maternal and newborn health. The second one, we use IPV screening to measure to reduce crime or domestic violence. The third one, we use child maltreatment to reduce child injuries, abuse, and neglects. The last one, to improve school readiness and achievement, we use data from parent-child interaction, early language and literacy, and developmental screening data. The last 2 additional domains that support healthy home visiting are improved economic situation and improved coordination in referrals across services. A lot of this information is technically spelled out in attachment 6 of your contract. So now let's focus on the program measures and supporting data needs by population group. Home visiting services accounts funded programs are required to report on a total of 8 Align measures. These are listed here based on the population measures. Starting at the left side of the screen, at enrollment, you will need to collect parental or guardian consent and demographic information. Then for each population, we listed out measures that need to be considered. For example, intimate partner violence or IPV screening is required early on in your engagement with a new caregiver, within 6 months of enrollment, while other measures focus on the age of the child, such as breastfeeding or well child visits. Infant birth if enrolled prenatally, child's actual birthday and expected due date. Both are important to determine gestational age, important for developmental screenings. Complete a PHQ-9 depression screening within 92 days of birth or enrollment. You'll begin recording well child visits. On an annual basis, you complete a language and literacy survey, which is a simple question about how often parents are reading or engaging in literacy activities with their kiddos. Complete an intimate partner violence screening within 6 months of enrollment. Infancy before 12 months, complete a breastfeeding survey. Access how many children are still being breastfed any amount at 6 months of age. Continue recording well child visits and dates. Language and literacy survey question recorded once each report year for each child. Developmental screening take place at 9, 18, 24, and or 30 months. Parent-child interaction observation tool using the HOME, HOME, once per report year. After 12 months, looks pretty similar. The biggest difference is that there are some demographics you will need to update on an annual basis. Collecting child maltreatment data annually, but we do the linkages annually. So we don't collecting the consent every year, but we update it if needed, and we do the linkage annually. This slide is only about the data collection and production of the 8 aligned measures. For child maltreatment, we look at interaction with CPS each year. We don't need to recollect the consent as mentioned earlier, but we do reach out each year to CPS to see if any families met the measure of engagement with CPS. This is kind of a nice overview of frequency of data collection. For example, IPV screening, we only collected one time. So a depression screening and breastfeeding at 6 months. It's very time specific for those measures. So if you miss the data collection time frame, that family won't be measured for that, won't be qualified for that measure. Well child visit will be multiple. So at developmental screening, there's very specific time frame when you need to collect them as well. Parent-child interaction and early language literacy is only once per child per year. In the child maltreatment, as mentioned, we only collected one time, but every year, Department of Health update the annual linkage. Eligibility considerations. Eligibility for inclusion in a measure may be determined by a number of factors. First, enrollment entry or duration. Did the participant enroll early enough, and has participant been enrolled long enough to access these measures? For example, breastfeeding requires prenatal enrollment, and depression screen requires 3 months of enrollment. So if these time marks already passed, then the family won't be qualified for the measures. Age, does the child meet the age criteria during the report period? For example, developmental screen requires child to be between 9 to 31 months of age. Screening window, did the screening window open or close during the report period? For example, IPV screening period ends at 6 months. Evaluate in year when window ends. And the report year, was participant assessed and reported on during a previous report period? For example, if a child met 24-month developmental screening prior year, then we no longer assess that child anymore. Now let's dive into specific measures. The first one, align measure number 1, breastfeeding. The direction, collect breastfeeding status when infant reaches at least 6 months of age and before child's first birthday. You don't want to do it too early because then it won't count. You want to wait collect the breastfeeding status when the child after 6 months of age. The definition is the percent of infants among mothers who enrolled in home visiting prenatally who were breastfed any amount at 6 months of age. So after the infant reaches 6 months, complete a breastfeed survey. It does not need to be exclusive breastfeeding. What we are capturing is how many children are still receiving any amount of breast milk at and after 6 months of age. Collect as close to that post-6-month window as possible, but the only requirement is that the infant is at least 6 months of age. The required data elements include family enrollment date, child date of birth, child due date if enrolled prenatally, breastfeeding survey date, breastfeeding survey result. The eligibility criteria, as I mentioned, mother must enroll prenatally and child reach at least 6 months to 12 months of age during report period. Data entry location is usually child health info. The second aligned measure is depression screening. The definition of depression screening measures is the percent of primary caregivers enrolled in home visiting who are screened for depression using the PHQ-9 tool within 3 months of delivery if enrolled pregnant, or 3 months of enrollment if enrolled postnatally. So the measure is only measured once within 92 days of enrollment or birth, or 92 days of enrollment if enrolled postnatally. For the aligned measures, we will only count screens that occur within that 92-day window. Screening that occur outside that window will not be included. The required data elements for it is family enrollment date, so we can calculate the window, child date of birth if enrolled prenatally, PHQ-9 date, PHQ-9 result, for example, referral needed or doesn't need referral. Data entry location for depression screening fall under either family assessments or guardian assessments. The aligned measures number 3 is well-child visits. The definitions of the measures is the percent of children enrolled in home visiting who received the last recommended well-child visit based on the American Academy of Pediatrics AAP schedule, which is calculated based on the child's age at the date of the family's last home visit in the report period. Collecting information about well-child visits at every visit ensures data is captured at the last visit of the report year. We are looking to see if each child received the last well-child visit they are eligible to receive based on a standard AAP schedule and at the age of the child at the last home visit. We recommend that you collect this data as often as possible. Required data elements for these measures is child date of birth, date of last home visit, and date of last well-child medical visit. The aligned measure number 4 is child maltreatment. Child maltreatment measures is the percent of enrolled children with at least one investigated case of maltreatment following enrollment and within the reporting period. Consent to share personal data is required, but if the consent answer is no, the family still continue receiving home visiting services. The direction to collect this data is to complete an informed consent form with the guardian within first 3 visits. Home visiting services account uses this information to identify any cases reported to CPS. We define this measure as the percent of children enrolled in home visiting with at least one investigated case of maltreatment that occurred following enrollment during the report period. We will need a signed consent form for all clients to share identifier data. We will then send names of clients and children to DHHS, who will link the data to their records. DHHS then sends us back the list which we use for the reporting. For local implementing agencies who do not use Visit Tracker, please use the Excel template to submit consent information to the Department of Health through the SFT website. For more information, please go to our webpage to learn more about this section. The values of managing confidential home visiting services account data is all confidential data will be protected. Data security system and steps in place to ensure that personal data is only shared with intent and with protections in place at receiving end. We are able to ensure consent data sharing is HIPAA compliant, which the tracking data we will be able to identify where, when, why, and with whom data is shared. The process includes confidential data is only used to allow us to link our home visiting data with other state data systems in order to provide more information on the success of our families across the continuum of services. Let's look at a real sample, how we use consented home visiting data to measure child maltreatment, defined as CPS-initiated referrals or investigations. First, the guardian grants the consent, then local implementing agency provides data to DOH, including name, address, Medicaid number, guardian date of birth, permission to use audio information, share with DHHS or DA. From there, RDA takes home visiting services account data and extracts any CPS case data linked to CPS data and send that list to home visiting data account. No home visiting services account data saved in CPS database. We want to emphasize that. Home visiting services account data does not merge into CPS database. The CPS data is merged into our data set. Home visiting services account data is not used to initiate any investigations. CPS does not see our data as it is handled by research and data analysts as an honest broker. The aligned measures number 5 is parent-child interaction, which is the percent of primary caregivers enrolled in home visiting who receive an observation of caregiver-child interaction using a validated parent-child interaction tool. Validated tools used by the home visiting services account are the Home, HOME, Dance, DANCE, and Piccolo, PICCOLO. Measured once within 92 days of enrollment or birth. Ideally, you can space the 12 months apart, so if you do the tour in September, wait until the following September or the next year. The required data elements include child ID of observed child date of birth, date of parent-child interaction assessment, and tool used. The aligned measure number 6 is early language and literacy. The definition of the measure is the percent of children enrolled in home visiting with a family member who reported that during a typical week, they read, told stories, and or sang songs with their child daily, every day. The measure is measured once within 92 days of enrollment or birth. The direction how to collect the data, this only needs to be collected and recorded once per report year. Specific question to use for the data collection is to ask the caregiver the question during a typical week, how many days do you and or any family member read, tell story, and sing songs to your child? The answer to this question will be a number between 0 and 7, and again, this is just a typical week, not a specific week. The aligned measure number 7 is developmental screening, which is probably the most complicated only because the time windows are very specific. The definition of the measure is the percent of children enrolled in home visiting with a timely screen for developmental delays using a validated parent-completed tool. You complete an ASQ3 screening at 9, 18, 24, or 30 months, depends on your programs. There is a unique form for each age window. Again, each has a very specific window for completion, and screening that occur outside of these windows will not count toward the measure. Also, just to note, the ASQ3 is different from the ASQ-SE if that is something you are familiar with. The SE is a social emotional screening and doesn't count toward the measure. Required data elements are children date of birth, date of ASQ3 screen, and date of diagnosis. There are special circumstances about developmental screening that I want to share, only assessing 3 screens. So we either screen 9 or 10 months or 24 or 30 months, specifically depends on your programs. And they must be in the screening window. If a child born premature, then adjust the screening window period per ASQ3 guidance. If a child has diagnosed developmental delay, then document that in your data system. Additional screening are not required if the child has a diagnosed delay. However, if you do the screening in the window, then it will be counted toward the measures. The key data for data collection is child date of birth to calculate age, child's gestational age, a preemie baby, ASQ3 date is documented, and the diagnosis indicated. The allied measures number 8 is IPV screening. IPV screening is defined as the percent of primary caregivers enrolled in home visiting who are screened for intimate partner violence IPV screen within 6 months of enrollment using a validated tool. Again, the measure is measured once within 92 days of enrollment or birth. This is 6 months of enrollment, regardless of prenatal or postnatal enrollment. Within the first 6 months of enrollment, complete a validated screening tool. The validated tool is the Relationship Assessment Tool, or RAT. This is the same tool as the WEB, Women's Experience with Battering. This tool is from Futures Without Violence, will often referred to as the future screening. Required data elements are family enrollment date, family exit date if applicable, Relationship Assessment Tool RAT screening date, IPV intimate partner violence screening result, referral needed or does needed. The last piece of our orientation is talking about performance payment measures, which is demonstrated in the dashboard, which you receive quarterly. The first section you will see in your dashboard is enrollment performance milestone, which is the average quarterly enrollment meets or exceeds 90% of maximum service capacity. So we calculate the number of families actively enrolled on the last day of each month and average across 3 months. Actively enrolled means a participant receives at least 1 visit or encounter during COVID-19 in the prior 3 months. The formula for that is the average of the number of families actively enrolled on the last day of the month 1, month 2, and month 3 of the quarter, divided by the maximum service capacity, also known as funded caseload. Required data elements for it is family enrollment date, family exit date if applicable, visit dates, visit durations, and encounter dates. This slide is just a repeat of previous slide talking the enrollment and performance pay measure. Again, the percent of funded slots filled during the quarter is calculated as the average number of actively enrolled home visiting services at CAL clients on the last day of month 1, month 2, and month 3 of the quarter, divided by the total number of funded HVSA funded slot. Actively enrolled is defined as enrolled on the last day of month and had at least 1 visit within the prior 3 months. During COVID-19, active enrollment is satisfied by a visit or an encounter within 3 months of month end. Funded slots is the number of family slots covered by your contract, also known as maximum service capacity, stated in your dashboard. And here is a snapshot of quarterly enrollment that you will see in your dashboard location. The first column is the enrollment performance measure of your program. The second column you will see is for total from the models, and the last column is all in the state. The second section in performance payment measure, also demonstrated in the dashboard, is family retention milestone at 12 months, which is defined as the number of enrolled participants who have not exited and received a visit or encounter between 30 days before and or 30 days after the 1-year anniversary of their enrollment date. The characteristic listed below has been identified as related to early exits among the home visiting services account participant. Teenage patient, parent is less than 20 years old at enrollment, parent has less than high school education among non-teen parents at enrollment, homelessness on the street or living in the group home or shelter reported anytime during service, participating on TANF reported anytime during the service, not residing with a romantic partner, single, divorce, or widow, reported anytime during services. The required data elements are family re-enrollment date, family exit date, visit duration, encounter date, and additional data elements are caregiver date of birth, caregiver education, caregiver housing status, TANF participation, caregiver marital status. All of these data will help us to understand more about the services that we are providing. Same at family retention milestone at 12 months. Family retention milestone at 18 months are defined as number of enrolled participants who have not exited and received a visit or encounter between 30 days before and or 30 days after the 18-month anniversary of their enrollment date. Retention 12 months and 18 months you can find in the dashboard location with the left-handed bar graph. In the dashboard, it shows 3, 6, 12, and 18 months. But to be qualified for performance payment measure, it's only 12 months and 18-month retentions is required. The last piece in performance pay measure is depression screening milestone. The definition of depression screening milestone is the completion of a depression screening for an enrolled primary caregiver using an approved, validated tool within 3 months after enrollment, if enrolled postnatally. The required data elements are family enrollment date, child date of birth if enrolled prenatally, PHQ-9 date, and PHQ-9 result. Only PAT or portfolio programs are qualified for second depression screening. The completion of a depression screening during the second year of participation for an enrolled primary caregivers using the same approved, validated tool. Programs may receive this payment only once per participant. It will be the same. Required data elements are required. Family enrollment date, PHQ-9 date, and PHQ-9 result. If the depression screening is positive and a service connection or referral identified, then will be qualified for the depression referral and service connection payments. Number of participants who screen positive for depression who are preferred to or connected with services during the contract year, programs may receive this payment only once per participant over the period of their enrollment. The required data elements also include enrollment date, child date of birth, PHQ-9 date, PHQ-9 result, already receiving services date, referral given date, and referral completed date. Now let's look at the definition of depression referral and the criteria to be eligible for it again. The number of caregivers who received and or completed a depression referrals is the number of primary caregivers who screened positive for depression who were referred or connected to appropriate services during the contract year. Positive screen means the moderate or severe depression, which is the PHQ-9 score greater than or equal 10 and or suicidal ideation. Referral or connected means documented referral with or without confirmation that caregiver received services. The time period criteria is positive screen date can be any time during current or previous contract year. Referral given completed date must be in the current contract year to be eligible for that year. This is a snapshot where you can find all the depression screen and referral in the dashboard. The first number is initial screen, and the second number is the second screen, and the bottom number is the total primary caregiver screen positive for depressions. So it's not the total of the first two. The last number is the number of all the positive screening for depression screening. And it should be equal to all the number in the pie chart on the right side hand. This is our team as Department of Health Home Visiting Unit contacts. Please feel free to reach out to us at homevisiting@doh.wa.gov for any concern or problems. Thank you and have a wonderful day.